Hi, my name is Anmol Singh, and today I'm going to present the case study of Mr. David Neese. Mr. David Neese is a 72 years old man with a history of COPD, hypertension, hyperlipidemia. He is currently experiencing acute exacerbation of COPD, which is worsened by the bacterial infection and COVID-19 diagnosis. He is presented to the emergency department with the respiratory distress, hypoxemia, and signs of cardiovascular strain. His A to E assessment is airway patent, maintaining his own, sitting in tripod position, no immediate obstruction in the airway. Breathing, his respiratory rate is 30 per minute, which indicate tachypnea. The SpO2 levels is 78%, indicate hypoxemia. Crackles and wheezing sounds are present. He's using his accessory muscles for breathing. Circulation, his heart rate is 134 per minute, which indicate tachycardia. The blood pressure is 158 by 95, indicating hypertension. His capillary refill timing is prolonged. He's peripherally pale and cool. Disability, Mr. Nice is mildly confused. His Glasgow Coma Scale is 14. Pupils are equal and reactive. Exposure, Mr. David is febrile. Abdomen is non-tender. Bowel sounds present. Diagnostic results. Chest X-ray reveals hyperinflation of lungs, indicate chronic air trapping and cardiomegaly. Arterial blood gas analysis. PaO2 is 62, which is low, indicate hypoxemia. PaCO2 is 56, which is elevated, indicate hypercapnia. The pH is 7.30, indicate respiratory acidosis. Blood count. The WBC and neutrophils are elevated. These indicate infection. CRP levels are also elevated, and this also indicates systemic inflammation. COVID-19 PCR positive indicate viral infection. Clinical decision making, airway, monitor the airway and check for deterioration. Suction for the mucus buildup and retention. Maintain clean airway. Breathing, hypoxemia and hypercapnia indicate respiratory distress and failure. There is need to restore adequate SpO2 levels and regularly monitor by pulse oximetry. Circulation, tachycardia and hypertension is a compensatory mechanism for respiratory failure. It needs attention to prevent corpulmonary-like complications. Cardiac monitoring by continuous ECG and interventions required. Disability, he's confused. This indicates CO2 retention. Monitor for his neurological status hourly and improve the oxygenation. Exposure, fever is due to the bacterial infection and indicated by the increased inflammatory markers in the blood. Antibiotic therapy and temperature monitoring is required. Infection control precautions are also required to prevent the spread of COVID-19 infection. Now, the nursing interventions. Control oxygen therapy to maintain SpO2 between 88 to 92%. Infection control by isolation to prevent spread of COVID-19. Administration of bronchodilators, prednisolone to reduce inflammation in the airway and improve respiratory function. Cardiac monitoring, such as continuous ECG to detect arrhythmias due to the hypoxia and increased cardiac strain. IV fluids to support circulation and improve perfusion. Antibiotic administration for suspected bacterial infection. Antiviral therapy to manage COVID-19 infection. Monitor airway patency and prepare for suctioning if needed. ABG monitoring every 4 hours to know oxygenation, ventilation, and acid-base balance. Monitor for signs of sepsis. Reassess neurological status frequently, and monitor for deterioration. So this is the diagram representing the relation between COVID and COPD, how COVID exacerbate the COPD and the symptoms, and how the virus react and how it spreads the infection. Now coming on to high priority interventions. Control oxygen therapy. First is control oxygen therapy. This is to keep the SpO2 levels between 88 to 92%. In Mr. Nee's case, his SpO2 is critically low. And improving oxygen saturation is vital to prevent respiratory failure and oxygen dysfunction, organ dysfunction. Rationale prevent oxygen-induced hypercapnia and respiratory depression while ensuring adequate oxygenation. Next is the COVID-19 management. Isolate the patient in an active pressure room, implement infection control precaution, and monitor for the progression of COVID-19 symptoms. Rationale to prevent the transmission of virus to the other patients and staff as the virus is highly contagious. This is the graph we show the mortality rate related to the oxygen therapy. Now, administration of salbutamol puffer, PRN. Bronchodilators like salbutamol reduce bronchoconstriction. This allow better airflow and gas exchange in the lungs. Administering this medication will relieve the acute dyspnea Mr. Nice is experiencing and reduce the use of accessory muscles. Rationale, reduce bronchoconstriction, allow better airflow and gas exchange in lungs. And the final fourth intervention is administering the antibiotics like azithromycin, rationale to treat the chest infection. And there is also need for the sputum culture so as to identify the specific bacteria which is causing the infection and to start the specific antibiotic therapy. Now, nursing responsibilities for medication administration. First is the oxygen therapy assessment. Regularly monitor oxygen saturation using pulse oximetry to maintain SpO2 between 88 to 92%. This is the target range for COPD patients. Administration is used via nasal prongs or Hudson mask as prescribed. Side effects, hypercapnia. It can because due to the over-oxygenation leading to CO2 retention. Next is salbutamol and ipratropium. Assess the baseline respiratory status such as breath sounds and respiratory rate. Administer using inhaler or nebulizer will ensure proper technique using a spacer. Instruct the patient to take deep, slow breaths during inhalation and hold their breath for a few seconds after each dose. Side effects, tachycardia, tremor, nervousness, dry mouth, and throat irritation can also occur. Next is prednisolone. Monitor for the signs of airway inflammation. Administer orally with the food. Side effects, GI upset, insomnia, increased blood sugar levels, and mood changes. Azithromycin check for baseline symptoms of infection, such as purulent sputum, fever, and elevated WBCs. Administer IV or orally as prescribed. Advise the patient to take it with food if he's taking orally. Side effects, GI upset, nausea, and cardiac arrhythmia. Now, nirmatrelvir and ritonavir. Assessment, rat test, and PCR test for COVID-19. Administer orally. Side effects, GI upset, nausea, diarrhea, altered taste, hepatitis, and jaundice can also occur. Next is the diagnostic procedure for COPD. The diagnostic procedure for COPD is spirometry. It is the commonly used diagnostic test to diagnose COPD. It measures the volume of air a patient can forcibly exhale after a full inhalation. This provides key values such as force, expiratory volume in 1 second, and force vital capacity. The ratio between the two is used to confirm airflow obstruction. The ratio less than 0.7 indicate COPD. Now, the nursing responsibilities related to this spirometry. Patient education and consent. In Mr. David's case, we'll educate Mr. David about the test and how it will be performed, and we'll take the consent before proceeding with the test. Next is infection control measure to prevent the COVID-19 spread. We know that Mr. David is positive for the COVID, so we'll take every precautions needed to prevent the spread of COVID. So we'll use the proper PPE kit before performing the test. Next is support and guidance during the procedure. We'll guide Mr. David through each and every step on how to sit, about the posture, and we'll guide him to take a full inhalation and then forcefully expirate into the apparatus to get the appropriate readings. And the third is documentation of the results. We'll document the results after the test, and we'll also tell Mr. David to follow up with the doctor for the further treatment. Thank you.